Thank you all for attending today's webinar. This is the fourth webinar in our 8-part series, Home Matters, Rethinking Aged Care Design, that we're running with Dementia Training Australia. I'm Genevieve Donnelly and I'm the Assistant Secretary for the Department for Dementia, Diversity and Design. I'd like to begin by acknowledging the traditional custodians of the lands on which we are all virtually meeting today. I'm based in Canberra on the lands of the Ngunnawal people. I acknowledge and pay respect to their continuing culture and the contribution that they make to the life of this city and this region. I also extend that acknowledgement and respect to other families with a connection to this region and any other Aboriginal and Torres Strait Islander people who are here with us today. There will be a Q&A session at the end of this webinar. Please submit questions in the Q&A function. You may need to click on the Q&A icon at the top of your screen to activate the function before submitting any questions. You can upvote questions that other participants post, and this will help guide which ones are directed to our panelists when we go to that part of the session. There is a difference between liking and upvoting functions. Liking a question won't change its position on the screen. Upvoting it will help push it up the list of questions. We will attempt to respond to as many questions as possible. Questions and answers, including ones that we may not get to today, will be published in a frequently asked questions document on our website. Questions submitted during the registration process have also been considered for our question and answer session today. We do sometimes receive questions that are a little unclear or not directly relevant to the webinar. During this session, we will only be answering and responding to those questions relevant to today's topic. Other questions will be directed to the relevant areas of the department and addressed through the frequently asked questions document. There's no option for attendees to turn on their video or microphones today. Webinar slides are now available on our website. This session is being recorded and will be published on our website. Participants will be emailed links to the recordings when they become available. Today's webinar shines a spotlight on the home in aged care homes. We'll explore the second principle in the National Aged Care Design Principles and Guidelines, Cultivate a Home, and how environments can be designed to feel familiar, personal and supportive of everyday life. In this session, you'll learn about designing households and spaces that foster privacy, control and belonging while being safe places to work. We know that large-scale institutional environments can be overwhelming and disorienting for many older people, particularly those living with dementia. Smaller, familiar and more domestic settings support better outcomes for both residents and staff. Cultivating a home goes beyond bricks and mortar though. It's about how people experience living in a place and whether it feels personable, predictable and respectful of who they are. It means designing environments and models of care that support choice and control in everyday life so that people feel a genuine sense of belonging in their homes. Before we begin, I'd like to sincerely thank our panel members for their generosity in contributing to today's session. We're deeply appreciative of the time you've given and the depth of experience you bring, particularly your pioneering work in implementing small household models across the aged care sector. Your leadership and willingness to share lessons from practice continue to shape how we think about creating more humane and livable aged care environments. I'll now pass to Nick Seaman from Dementia Training Australia to host today's session and introduce our speakers. Thanks, Nick.
Thank you very much, Genevieve. This is a session I've really been looking forward to. The second principle, being Cultivate a Home, could just as easily be called What do we mean by meaningful life, or how do we make places meaningful to be in? The material that went into the principles and guidelines on small households, it goes back a long way. This is a book well worn and used. The Design for Dementia that goes back to 1998. I can see Angela smiling at that. And I've seen reference to small households going back to CADE units in the 80s on courier script that was written out there. So it's not new. The greenhouse projects have existed in America since last century. It's the end of the 90s that Hammond Care built its first household model homes and started to transform that organisation. Natasha's work in New Directions Belmere goes back now, I think, almost 10 years, and she'll talk about that later on. So this is not new. And what we're going to do today is unpack what we mean by a small household model, discuss key design elements, and will outline how you can shift a facility or some of the strategies to start to do that. So I'm going to start by introducing today's speakers. I'm really thrilled about this. I've been listening to and watching and meeting with or hearing both Angela and Natasha talk through the last 20 years. We're going to first hear from Natasha and then we'll hear from Angela. I'm going to start though with Angela. Angela is somebody who I've listened to so many podcasts where it comes back to somebody asks a question and her response is, it's about treating people as individuals and with respect and not treating them as a herd. And that's gone through every time I've heard Angela speak, whether it was about households or anything else. It comes down to, if you know the residents living there, if you put the staff in a position to know them, it's all wins. So what I've got here for Angela is that she's the head of aged care now at the Salvation Army Australia, where she leads a national portfolio of residential aged care, home care and services supporting vulnerable older Australians. Angela's a registered nurse. She's got a background of more than 30 years of experience in the aged care sector. She was a senior leader in Hammond Care and was part of that transformation, or as I experienced Hammond Care, was part of that transformation over the last 25 years to what we now see as Hammond Care as a leading proponent of small households and a leading supporter of people with dementia and complex care needs. Angela's recognised for her commitment to person-centred care, for championing services that support dignity, independence and quality of life for older people. In her current role, Angela focuses on strengthening compassionate, high-quality care for those at risk of disadvantage, including older people experiencing homelessness, mental health challenges and isolation. And that's a role that Angela's moved into, where I know the Salvation Army has a portfolio that goes back over decades and decades, long before the material that we're talking about today was being talked about. So plenty of challenges there. Welcome, Angela. Natasha. So again, Natasha's another one of my heroes. I first met Natasha more than 10 years ago, before New Directions Care in Queensland was built. She's the founder and CEO of New Directions Care. And when I first met Natasha, it was actually in the context of a person who's no longer with us, but who was a close friend, who spoke so highly of Natasha and the fact that he was somebody who was working outside of the not-for-profit sector, but in an area where it was filled with compassion and really, how can we support older people? And so my first introduction to Natasha was from somebody saying how wonderful Natasha is, how focused she is on, again, the residents and the people who are living there. So Natasha's founder and CEO of New Directions Care, an award-winning aged care organisation recognised internationally for reimagining residential aged care. She's got more than 20 years of experience in the sector and has worked as a consultant and operator and an industry leader, including serving as National Executive Officer of the National Association of Nursing Homes and Private Hospitals. Natasha's vision to transform traditional institutional models of care drove to her founding New Directions Care and building it. She's created a place there that prioritises autonomy, connection and well-being. Her pioneering micro-town model, which we're going to hear about, was first developed in Belmere. It's now gained global attention for its innovative approach for supporting people living with dementia and complex care needs. And from our conversations preparing for today, Natasha says probably 800 people from different organisations have come to learn what she's doing. And so she's managed to successfully really pilot something that shows you can do what we're going to talk about today, and you can do it in a way which is affordable, manageable, works. And she'll talk a bit more about that later on. Before we go into their talks, I'm going to give a little bit of a background to what we're talking about here. So in terms of the National Aged Care Design Principles and Guidelines, my interest and involvement starts off in a lot of ways with reading Atul Gawande's Being Mortal, where he talks about the origins of residential aged care as going back to public hospitals of 100 years ago, and the way in which, as it emerged, there was an idea of how can we actually look after people in an affordable way. It was about how can we afford things, how can we keep people alive? And that led to a world that we no longer remember, really. And it's important to realise how far we've come. Because when I first started looking at care homes in the late 80s, they were places that didn't look like they look today in most cases, and it wasn't responding to what we see. So what we expect has changed dramatically, and it should have over that 30-year period. But if we go back 20 years, we're talking about a time when multi-bedded rooms were the norm, and we talk about multi-bedded rooms as 2 bedrooms. I remember when there were 8 bedrooms. And so people were sleeping in dormitories for 8 people, and we've come this big distance, right? Many homes didn't have any access to gardens, and people really were in a herded environment where they were just being kept there. Just the poor cousins of the public hospital system. And I think it's important to remember that we've actually come this distance. And at the point in time in 2021, when the Royal Commission actually introduced the idea of there being National Aged Care Design Principles and Guidelines, they actually recommended there be principles and guidelines. They recognised that there was a need to go further, and that they prioritised the idea of the principles and guidelines should be built around a small household model as one of their recommendations. And they also talked about funding that related to the upgrade of buildings, which now, in the last ACAP round, was about there being funding that was supporting that shift towards small household models. So I'm going to just go to the next slide that shows those 4 principles. And it says, here are the 4 principles. Each one of these for us was about us saying, where is an issue where we understand that there's an evidence base saying we can move a little bit further. And so we talked 2 weeks ago about enabling the person, which was about when people move into a care environment, into a care home, the environment should be supporting their mobility and navigation. It should be giving them an ability to be as independent as they possibly can be. And it should be finding ways where the challenges they've got through sensory, cognitive, or frailty-related impairments, the building's trying to help compensate for that. When we talk about cultivating a home, I'm going to go back to an article that was written by Susan Dyer in 2018 that talked about actually looking at the financial reality of a small care home model versus a traditional model. And Susan was also involved in a paper on innovative care models relating to the work for the Royal Commission. And she defined a small household model as having 5 of the following characteristics. The first one was that there should be small units of 15 people or less. The second one was independent access to outdoor areas. The third one was that there would be allocation of staff to specific living units. A fourth one was meals prepared in units. There's another one which is about self-service of meals by residents, and there's an involvement of residents in participation in preparation of meals. So she was basically saying, look, you've got some combination of these, but what are we talking about? A smaller group living environment. I once asked her where 15 came from, and she said, oh, look, it's a general idea of what we think is okay. And I said, so bigger would be fine. And she said, well, you can go a bit bigger. And I said, so like 18. And she went, no, by bigger, I meant 16. So she was saying the evidence is 15 or less is actually better for care. It's less busy, it's less noisy. If you can go smaller and justify that, that's even better. But the mark internationally has been set as, can we set up a situation of 15 people or less together? So I'm going to just go through underneath each of the principles, we set up a series of guidelines. So on the next slide, we've got 11 guidelines that sit underneath the principle of cultivate a home. And what we've got here are a series of ideas. These are flexible to different cultural situations. So a lot of people talk about the feedback we've had on the principles and guidelines is, where does cultural difference come in? Our expectation when we wrote these was people will take a guideline and reinterpret it to their particular climate, situation, the cultural group they're working with. But here are the considerations that are a significant way of how we build up an idea of a small household model, how we can cultivate a home. So the first one I'm going to talk about in a bit more detail. I'm going to talk about 5. The first one is about the actual idea of a small household. And that's what I was saying, where there are 15 people or less living together, and an idea that that group is one where there can be a more immediate relationship with staff who are relating to these 15 people as people within that household, a smaller group. At any point in time, it doesn't mean that we're taking 15 people from activity to activity. The idea is this is allowing the greatest possibility for people to be doing different things supported in what they're doing. The next principle I'm just going to outline slightly is one that is about private entries. The basic idea and the reason we said entries is because if there's no entry, then there's no household. And what I mean by that is I've been in places where a larger home is broken down into clusters of 15, but there's no division between the different clusters. So it's still a 30 or 45 or 60 person social group. And so the idea is you've got a front door, you come into that group of 15, and that's your home. And we might slip into language like what makes something home-like or that sort of idea as we go through today. But the reality is we're talking about home. So not home-like, but I think what we'll get from both of the speakers today is this wonderful idea of how do you actually help somebody maintain home rather than make something home-like. So the private entry gives you that. A core part, the next guideline is a core part of any household model is actually the kitchen. And you saw how many of those ideas I went through that Susan and I talked about come back to food. Food is fundamental to who we are. I get home, I start making a meal. I'm not expecting that that's any different in terms of the significance to me of my cup of coffee in the morning, breakfast, a meal. These are things that are part of our lives. So it might be that in different situations, there are interpretations of what that kitchen actually is or what it's doing. But the key elements are you can cook there. It's not a kitchenette. It's somewhere where you can prepare a meal, where staff can sit there and prepare a meal together with a resident, maybe with their family. And so that idea of a meal and the engagement with residents to whatever extent they can and want to in that meal preparation is an important part of that. We'll unpack that a little bit further later. The next of the guidelines we talked about was clinical support. And the key thing here is that clinical support is hidden. So people are moving into care homes because they need clinical support. There's no question about that. But how can we do things where it doesn't look like a nurse's station in control of the floor, or it doesn't look like there's signs everywhere, and we talked about visual clutter last time, but how can we do things where here is a photograph of a nurse's station in a care home. It's a spot by the side where they can do some work. I know in some of the Hammond care facilities, it's a spot out the back where it's concealed, and the image of the diagram on the side is saying, what can we hide of the clinical life? So it really is about the home life or the residential life. And the last of the guidelines I'm going to just touch upon before we bring Natasha back into the actually that was the last one, sorry, we've run through those. That was the last of the guidelines I wanted to go through. So there are 11. We've picked out a few to introduce them of a smaller group, a kitchen at the centre, and the idea that this is somewhere that is my home. So I'm now going to bring Natasha into the conversation and really just ask her, well, we're going to pick up a conversation we started in preparation for this. And it really was on that whole idea of what do we mean by institutional care? What are we describing? Is it the building? Is it the care? Is it the daily routines? Welcome back, Natasha, and it's over to you.
Thanks, Nick. Appreciate it. Look, institutional care is really, or buildings, if you like, do not provide institutional care, okay? It's what we do within the place, within the building, the place and spaces, the environment that really denotes institutionalised care, in my opinion. And I think it's also backed up by a lot of research. It's what we do, not the building or the environment itself. However, the environment is an enabler. So it can either support and enable your care model, or it can restrict the way that you provide services and support to the people that live in that environment.
So when you're talking about the life and the institutional life, do you want to just run through some examples? Like we talked about enunciators and noise, that if that's beeping everywhere, that's institutional. What are like 3 other examples of things that you saw that you went, this isn't right?
Yes, so I think probably the biggest one, and if I was to ask, the audience, that the people on the webinar today, how many of them or how many of their staff went in this morning and woke a resident up so that they could actually get that resident prepared for the day to have a shower, because that staff member has to have a certain number of people ready to go down or go to the dining hall or the dining room for breakfast. If you're doing any of those things, you're actually tasking, and you're tasking around the resident, not with the resident, and immediately that sets up institutionalisation. So just something as simple as that, which people are doing every single day in aged care, but that really changes the life of the person who's living in that environment. Little things like, does a person have access? You were saying it before, can I make a cup of coffee or a cup of tea? Do I have, that equipment available to me? Can I go if I'm capable of doing it and able to, and do that for myself? Or do I have to wait for morning tea or the afternoon tea trolley, or, something like that? That they're just small examples, but the reality is, if you think about choice and control and all the things that we've been talking about, preceding our discussion, when you live at home, you have the freedom to do what you want to do when you want to do it. And really, anything that that impacts on you being able to do that can and requires somebody to support you to do that, can mean that you're in an institutional, type of framework.
Yeah, I once went to a care home where I was asking some questions of the person running it, and one of my questions was, so what time do people have breakfast? And she said 9:15. It was something like it was a set time. And I said, what about lunch? And the person said 12:15. And I said, yeah, but what if I want to come at 12? And she said, no, we make sure everybody's there at 12:15. And then her response was, because you could see I was questioning it a little bit, and her response was, after people had been here for a couple of months, they really liked the routine. And her boss was there and went, isn't that wonderful? It only takes us 2 months to drum out any left independence that people have, and so when you set up Belmere, you were trying to, New Directions Care Belmere, you were trying to do something quite different. You were coming out of that world and you wanted to do something different. Do you want to talk a little bit about that?
Yeah, look, I've been in the aged care sector for a long, long time, and I have operated traditional aged care. And, one of the things that I've always hated the whole time that I've been in the sector is that we lock people up. I've never understood why someone who's living with, a cognitive change is being, placed in a secure unit or being locked up, and therefore they don't have, access to anything other than the four walls that are around them, and oftentimes not even a garden that they can go out into. So that's been one of the drivers. But the main driver was a very personal driver. Nick and I talk about this often when I, speak to people. My mum was getting older. She was retiring, and I was really concerned about what would I want for her? What would I want for somebody that I loved if she actually did end up requiring care? And it was that, if you like, that was the catalyst for change for me. So this was, 14 years ago. And I went on a really significant journey, travelled around Australia, travelled around internationally, looked at, all of the best models, all the things where people were living a good life in care, and really tried to see what it was that those organisations or those places were doing, that we could potentially incorporate here in Australia. And everything for us is based on what I call our true north, which is essentially living as normal a life as possible while you're in care. So everything for us is about living normal life. How do I provide that? And that's whether it's it's whether or not that's sorry, I've totally lost my train of thought.
Yeah, so living a normal life. And we talked about all the things which are, I get up in the morning, I want a cup of coffee, I can go get a cup of coffee. That all the things where if I can have it at home, and I've heard you say it 100 times, so I feel like I can step in.
You could do it for me.
So if I can do it at home, can I do it here? And so what you've done is found a way of doing that. And I guess where I wanted to go with this was, in terms of what you're saying, because it's so different, before we even talk about the buildings, how are you setting up your staff? Like, what are you doing to say, this is what I want to have happen here, so that when somebody comes to work with you, they know exactly what they're doing and what you're expecting of them?
Yeah, look, I think one is we're introducing them to the places and spaces and what their purpose is. So just to give the people on the webinar, some understanding of what we've actually created. We have created what we call a microtown, And what that means essentially is that it looks like you walk in the door and it looks like a suburb or a small town in Australia. There's services up the front of the site, cafe, wellness centre, fully equipped gym, dental studio, GP clinic. There's a cinema. There's a hair and beauty salon, there's a barber shop, and there's a shop where all of the purchasing for that whole community is actually done from. And then you walk down a main spine, a street, and there are 6 streets. And on those 6 streets, there are 17 houses. Now, for us, a house is 7 residents only. So, we really focus on small house, not household model, if you like. And then in that house, everything operates the way that your home and mine do. Whether it's the laundry, whether it's the cleaning, whether it's the cooking, everything is done in that house by a universal worker who we have trademarked as a house companion.
Which means there's no commercial kitchen on the site, there's no commercial laundry on the site. It's literally happening there.
Everything happens in that house. And so when we're, bringing people on board, everything to us is about, do you meet the values of us as an organisation, our values, and also then will you be able to ensure that our vision is on a day-to-day basis in everything that you do, front of mind. And that's the house companion model. And essentially what that means is if you're going to cook a meal, then you make sure that anyone who might be interested in being involved in cooking that meal, whether it's sitting at the table talking to you about how they would have cooked it, or whether it's actually, them chopping up the vegetables for the meal that's going to be provided for the residents in that home, tonight, that they're involved. And really it is as simple as that. Sounds, everyone's probably going, oh gosh, how do you do that? But it really is as simple as that. When you have a relationship with residents, and it's a small number, so when you connect with them, you understand them as individuals, then you know what it is that they're interested in doing. And, we have some residents who want to be, in and out of the dishwasher, loading it, unloading it. We've got people who are living in the houses that are being involved in the cooking every day, doing their own laundry or doing it with the support. And then we've got plenty of others who say, nope, I'm happy for you to do that for me. Okay. Or they're not able to do it themselves. So we do it for them or with them.
There's just for everybody to know that the website's fantastic. It shows a lot of images. There are several images from Bellamy in the principles and guidelines. Yep. And so we intentionally didn't want to take on a visual tour because it's pretty easy to see. They're beautiful. They're beautiful scenes. So the cafe is a real cafe.
It's a real cafe.
And people go there a lot. Like it's a place that people are actually going on an outing, which is within reach from them and navigatable by them.
Absolutely. And so I think it's really important to understand, because I have such an aversion to locked, secure areas, the whole site's open. Every single house is open 24/7, and people can come and go and, stroll around their community just like they would if they were, still living at home on their own in a suburb. They're able to go to the shop. They're able to use their money in the shop, and if they don't have funds, then we, work out a different way for payment and things like that. Everything is real, and every single part of the precinct, if you like, is available and open to the external community. And I think that that's a really that's that intersection of external community and everyone who's living in that community as well. They're constantly seeing new people. They're constantly having the ability to converse and speak to other people.
So I'm going to a last question I'm going to ask just before we bring Natasha in, before we bring Angela in, is one of the questions that's actually already come up on the Q&A, which is about higher acuity of care, people having higher needs. And so with yours, if somebody, just as a sort of to finish up this little piece, if somebody's coming and they wander a lot, or if somebody's coming and their care needs are much higher, or if somebody's coming there and somehow their behaviour is difficult for other people, how can they still come there? How do you work with that?
Yeah, so absolutely. So we provide the same level of care that any other aged care community does in Australia. We're funded by the Department of Health. We're the same as nursing homes. We have about 80% of our residents who are living with a cognitive change. And a lot of the people living with cognitive change are at the highest level, so, advanced. It's an inclusive community. It's about educating the people who live in the community about the people that they're living with, as much as it is educating our staff so that they can support, both the person who is cognitively aware and the person who does have a cognition change. So everything that we do is at that same level. Our residents come to live with us, and 97% of our residents choose to stay and also have end of life in the same home, in the same room, that they came into many years ago. And that's, the other part of it. The quality of life for our residents is significantly higher. We've got a lot of, evidence that demonstrates that. And we also have about 12 months longer length of stay than you would see typically in the aged care industry.
I'm about to bring Angela into the conversation and focus on her work for a little bit, but I'm just going to say generally to people watching the webinar that we wanted to use the Q&A a little bit differently today. We're going to basically now, I'm going to talk to Angela for about 10 minutes about her work, and then the aim after that really is what are all the reasons people can't do this. So we're going to then go to a conversation of the three of us going through what the reasons are that people bring up why household is hard. So if on the Q&A, use that as an opportunity to put any questions up there of what you think makes it hard to do household, and Natasha and Andrew will be able to answer that through the Q&A through the third part. So I'll bring in Angela now because we wanted to shift from a situation here where it was very much Natasha setting up something new from scratch and all the ways that she did that, to your work, Angela, is much more around the reality for most people in the sector, where there are 3,000 aged care homes that exist across the country. Probably of those, over the last 20 years, I'm taking a punt at this, but maybe 5-10% have actually been replaced. And on the whole, most of the work is on how do we upgrade buildings? How do we take existing stock? And how do we actually make it work with what we want to do today? So that introduction I did was about that 20 years ago, we had different expectations. We were prepared to essentially accept something which today we, I think, as a community, are much more critical of, but we've still got buildings that were built then. And your work has been, how do you deal with all of that difficulty and the amazing challenges of how do you actually create households, both from cherry picking the buildings that you need to actually replace, but also fixing up the buildings so they can support household in existing environments. And I want to just start with you talking a bit about when you talk about household, what do you mean? And again, I know that with you, it's a lot more than the buildings. So if you can say, when you're talking about household and when you're introducing somebody to your work, what do you tell them?
Yeah, and look, I think what you've set the scene there really well, Nick, in that it's a luxury to have a greenfield site where you can sit down with a blank piece of paper and design small households. It gets a lot trickier when you are trying to look at what are some of those legacy buildings that were probably state of the art in their time, and the rate of being able to replenish that and build households. There's a reality that comes with that. And I think all the people on the webinar will be fully familiar with that. I always try and think about, as Natasha said, the building is an enabler. It's one tool that needs to sit within a holistic model of care that does focus on who is the person that I am providing this care and service to, and what does home actually mean to that individual. It isn't about the chandeliers. And I often, when you run sessions, you say to a group of people, put your hand up if home for you is about your marble bench top. Is it about how big your TV is? Is it about how many bedrooms you've got? Is it about, your furniture and your fittings? And almost irrevocably, people will put their hands up to say home is about the feeling. Home is about the level of control that I have. Home is about the ability to either be with those other people who I love and want to be with, or the ability to retreat and be on my own. So some of these things, when you're thinking about redeveloping sites, is thinking, what options do people have for privacy or community? What opportunities do people have for engagement or disengagement? I think we sometimes think that everything is about how much people engage, but we also have to remember everybody is different. And there are people who maybe have lived on their own for a long period of time. It isn't always what we think the person needs. And that's why, you did say that I was fairly consistent over my time in podcasts and webinars and what I think, because I do think knowing the person is the fundamental to being able to deliver a home. Ideally, it's small. Ideally, it's domestic in scale and familiar with the things that are around the person. But at its core, it's about knowing who each individual person is and what are the things that we can introduce that provide that person with the control and the option to retain their sense of belonging, independence, and freedom in the same way that we all take for granted.
So when we had Gwenda Darling on earlier, like in the first session, she used the example of when everyone talks about males, they're talking about like 8 people or sitting around a table or whatever. And for her, the experience of a male was sitting in front of television, and she wants to still be able to do that, having a male sitting in front of television by herself and not be lumped with a big group. And how does she experience that without having to be, oh, well, we'll leave you in your bedroom and we'll bring you a plated male. So
Or
what are the
without
things
her
that-
being labelled as, oh, she's isolating. No, she's making a choice. And so I think that, and knowing Gwenda, it's about knowing that that is her choice. It's not imposed upon her. So you talked about sort of what are the things that you need to think about when you're trying to look at different buildings, different environments, and how to maybe make some improvements. It does start with the staff culture, staff knowledge and understanding, and a belief that you're able to unravel some of those things that are task focused, institutionally driven, and efficient. I'll put that in inverted commas because it's about, unlearning as much as it is about learning new things when you're trying to change an existing environment.
So if, like, the example is if somebody's task is they need to go and get 10 people up out of bed every morning, and their KPI is I've gotten these people efficiently out of bed and they look nice and they're clean and they're on the way to the mail, that's the antithesis. That's the opposite of what you're looking at. So when you're looking at how you set up staff, what are the things that you're doing to set up a group of staff to make this work?
Well, I have a really foundational belief that you need to empower and engage the staff to be able to properly share what they know. So there's no point having a group of senior leaders sitting in a room and pontificating about how a household model is going to be the way forward and that's the future, and impose changes upon a group of staff without actually thinking about how can this group of staff and individually the staff help shape what we do and how we respond? What are the tools that we provide to our team in order to be able to provide that feedback around what's wrong with the routines, what's wrong with the tasks, what are the barriers to us as a frontline care team member, what's the barrier to me being able to achieve what you're telling me to do? So it's not enough to have those here is a directive. We're no longer waking people up and you're all going to be person-centered tomorrow. There's no value in that. We have to actually sit down with people, with the care teams, and understand how what it is that we expect from our care staff member, and what are the tools that we provide to enable the team to move away from the task focus. And I see a disconnect in that all the time. So the idea is there, the theory is there, the desire is there, but then we still have, you need to have made sure that you've documented all the bowel charts before you leave. Everybody's got to be on a 2-hour toileting schedule, and we've set up their care plans that it all happens within the same 2 hours. And the meals do arrive either in the bain-marie or from the kitchen at 8, 12 and 5. And so we don't establish those other elements to support the team to really have that truly person-centered approach. I also say we have to actually work alongside the department, regulators, and others, because to truly implement a model that values individuality and is able to respond, I saw a thing on LinkedIn the other day where somebody said, oh, Mum said once 10 years ago that she liked bacon and eggs, and now that's it. She gets bacon and eggs for breakfast every day and never gets asked again because it's on her form as that's a preference. But this is sometimes what drives what we think is person-centered, is this flip side of trying to have everything so neatly locked into a box that we only provide things that are on someone's care plan, that we only deliver the care that's all been documented, risk assessed, and that removes that element of spontaneity, which I think is fundamental to the home. So we have to be consistent in how we support frontline care workers, because you can't give them both instructions. You can't say, I want you to be person-centered, I want you to be responsive, I don't want you to run to a task-focused list. I want you to think about what the desires of the person are and engage with that person at every decision. And then at the same time say, you have to follow that care plan. It can only be what's on the care plan. If it's not risk assessed, it doesn't happen. Because that's a conundrum that if we don't resolve for that, we will continue to give mixed messages to our teams. And that's one of, I know we're not at barriers yet, but that is a barrier to being able to implement truly a domestic, home-like environment that enables people to belong and feel at home.
I'm going to shift it to the building itself now, in terms of that's about the setup and the fact that unless the organisation's aligned with what you're saying, unless the staff are there, you can't do anything. But I know architects who sat across the table from you, and I know the level to which you are passionate and adamant about what needs to happen. So whether it's a new building or you're looking at refurbishing buildings, what are like the key things that you're looking for when you've been there changing a building or trying to set a building up to be a household?
Well, one of the big things that's often missed is the concept of the workflows. So with the principal, it was great to see you talking about the fact that those things that are needed to deliver clinical care aren't obvious, aren't dominating the space. You're not sort of walking in and saying, well, it feels like a hospital because there's the nurse's station, there's the medication room. It's all lovely labelled with staff only, and excuse me, you can see where the pan room is, where your dirty linen room is, and you've got the skip in front of it. All of that screams institutional living. So I like to think about, when you're redoing some of those environments, creating the smaller spaces and trying to think about how you enable people to live well within their environment. You have to think about, how do you make it possible for staff to be able to follow through on what those principles are asking for. So you can't say, well, we've created this small household and now we're going to give staff a rabbit warren and 2 floors down for them to actually remove, dirty linen every time they need to get rid of dirty linen, or incontinence products, so that the place doesn't, where you got overflowing bin, because it's too far away for people to take the dirty linen out or the waste. You have to be able to think about, how do I work in this space, and where will those things be able to be efficiently out of the way so that we're not having that institutional creep. The other part of it is thinking about it. I always like to think about, you have to start from the person's personal space. So bedrooms, if there's nothing else that you can do but personalize bedroom spaces, and think about how you enable someone within their private space to be enabled. So how does wardrobe work for the person? How is their clothes available for people to be able to access and choose? Simple things. So starting at the bedroom and thinking about how you then expand from there to think about the whole home if you can't do it all at once. And using those small things to enable someone. So in bathrooms, how are we enabling people to be able to distinguish between what is a tiled wall and what is a basin, or what is the toilet, seeing the toilet seat? There are things that can be done in older, more institutional environments that promote independence in some of those very small functional ways. You don't have to think, well, I can't do it completely, therefore I'll do nothing.
Okay, I'm going to bring Natasha back in, and we're going to go straight into the issues that we'd raised beforehand that we'd thought through some of the barriers that come up, as well as the Q&A. And at the very end of the session, the last few minutes, I'll just go through the resources that we've got set up at DTA to support people further. But I'm just going to put up a few issues of what people say makes this hard, see where you go with it, and I'll bring in some of the questions that are coming up in the Q&A. The first thing which I always hear when I talk about as an architect, here's the household and we need a real kitchen, is safety issues. And I guess there's a question here for both of you about, if somebody's there saying, oh, but aren't knives dangerous, or isn't a boiling pot dangerous? You're both talking about buildings where real cooking is happening, where there are real knives. And how do you respond to somebody who's either a staff member or a family member saying, I'm worried, that seems unsafe to me? Do you want to go first, Natasha, and then we'll go to Angela?
Yeah, sure. So, look, from our perspective, you're creating a home. In every home, in every kitchen, you have, all your knives and forks and everything there that you can, all the tools that you need, if you like. But there are ways to make things safe. For example, our stovetops are convection. We have safety switches that will immediately shut them off if we need to. They're cold to the touch, so they don't actually, present a safety hazard, if you like. But the reality is we've only ever had one person, you know what I mean, in the whole time that we've been open. And we've been doing this for 14 years now across an older site as well as New Direction. So one person, had a burn, and that was the only time. So you've got to think about, by taking away, or by being too aware or trying to mitigate all risk, you take away everyone's right and responsibility and their ability to do anything. So it really is about looking at the individual person that's going into the house and how are they going to engage with those things. There's knives and forks in every drawer, in every single house. It doesn't matter who's living there. If there is an issue with a resident, then we work on that resident themselves. We don't take everything away from everyone else.
Angela, do you want to pop in?
Yeah, I think that's exactly right. It's actually about, again, knowing the people that you're providing that care and support to. And, often remembering that just because a person has a cognitive impairment, it doesn't mean that the person has no awareness of something that may be a dangerous environment. And often, one of the first things we learn as a young child is don't put your hand on a hot plate. And, that knives are, something that you shouldn't use inappropriately. And so I just think we sometimes assume that a cognitive impairment means, somebody doesn't know how to use a knife, or somehow starts to go, oh, I don't even know that it's unsafe, I'm going to start wandering around. I've had situations where a person who had very significant cognitive impairment, and she was given a potato peeler to peel the potatoes, and she was looking at it, and she was with the potato, and it was really obvious that this was not a tool that she knew how to use, and so gave her a small knife, and she peeled those potatoes in a way that I thought, we have to remember that people were using knives well before you and I were born, and cognitive impairment does not mean that you don't know what you're doing anymore.
Absolutely.
Okay, staying with you, Angela, a lot of the questions coming through and what we talked about again as the barriers people put up are about staffing, staff ratios, universal care workers versus task focused care workers. So some of the questions, and you can respond to them all, collectively, are about how do you deal with care minutes with universal staff? Do you need a universal staff member? When you've got 7 people in a household, Natasha, how do you actually staff that for 7 residents? And again, there's a question about, is it an infection control problem that you preempted of having a universal worker doing cleaning and then doing cooking? So those are questions firstly about how do you staff a household? How do you make it work? And then how do you actually deal with the fact that somebody's doing multiple things that we're used to breaking up a little bit? And how many people do you need? So do you want to go first to this one, Angela?
I would say that first and foremost, the care minutes concept and how that's begun to develop is actually problematic in my view. Not because I don't believe that we should be, as a sector, accountable to providing the right levels of care. And I certainly have no problem with saying it should be very transparent, reported upon, and the right amount of staff to ensure that people are able to get quality care and safe care. So I start with that. It's not about shirking accountability, but the care minute framework as it currently stands does actually challenge innovative models and that ability to think about what is required of a universal care worker. If you start counting nurse minutes, care worker minutes, and define them very clearly, and then you say we have to count lifestyle minutes and we count, you do start to create demarcation amongst how you deliver the care. But there is a way, and the way to have that, the care minutes and meet them, is to work through some of those time in motion, being able to discount the time that the universal care worker is working in kitchen, or, I mean, even though I still believe that is care, especially if engagement, that resident is a part of it. But for the purposes of care minutes are there, you have to comply with them. There is a way of being able to take that time to say, I am going to look at how much time people are spending on things that are technically not considered care, and you can pull that away and you can still demonstrate that you meet those care minutes and have the universal worker. But it does take more effort, which is why it does mean that you've got to get the buy-in at that provider level, and you need to have the investment to be able to achieve that.
Do you need a universal care worker model in order to make it work?
I think you do, because otherwise what happens if you don't have a universal care worker model? You end up with that, oh, I'll have to wait until, the person with the tea trolley comes because I'm not supposed to go into the kitchen, because if I go and help you with the cup of tea, then, so wait for the hospitality person. Or, oh, I know that right now is when you would love to have that opportunity to be able to sit down and go through your photo album. And I've always said for years, a person living with dementia, it's a window. It's often a window. It's not something that you say, if this is where the person is at right now, and we hear people always talking about meet the person where the person is at. Does that really work if lifestyle happens at 10 and 2? I don't know. I think that the universal worker enables true engagement.
Natasha, do you want to come in then and talk about what you do and how you deal with having only 7 people who are living in a household?
Absolutely. Firstly, the universal worker in our, or in my opinion, is the main reason for the success of the model and delivering the outcomes for the people who live there. So yes, it's vitally important. In terms of care minutes, it needs to be really looked at, and really understood what is it that particular team member, if you like, is actually doing. Because as Angela said, if I'm in the kitchen cooking a meal and I have a resident with me, then that is supporting that resident in terms of their support plan, in terms of enabling them to thrive, not just survive in an aged care setting. So we need to look at those issues. But for now, all we do is we have one staff member in every house as a minimum And then there are some houses that have 2 staff members, depending on the care and support needs that are required. And we also then have people who float, who move around the community. So if I have someone who requires 2 people to assist, then I call on another house companion to come in and work with me and support that person. So we also then have, you know, a full team of clinical and allied staff and lifestyle and, you know, everything else that is also there and available. And most of our residents, you know, once they've woken up and they've had their breakfast and they've gotten ready for the day, they're out in the community. So our house companions, you know, more often than not, have only got 1 or 2, sometimes 3 people that they're providing support to.
And that question that came about infection control, and isn't it a problem somebody's cleaning and then doing food? Natasha, if you go first and then Angela on this one.
Yeah, look, it's never been an issue. It is something, you know, like Angela said, we had to game all of this. We had to think about it before, you know, we were able to develop the worker and the systems around it. But in actual fact, infection prevention and control is and has been proven to be far more successful in small houses, you know, than it is in any institutionalized setting. And so, you know, it's like anything else. If you were cleaning up after your child who might have, you know, had an accident at home, that doesn't necessarily mean that you're doing anything more than cleaning yourself, washing your hands before you go into the kitchen to then make that child a meal. It's not any different. Really, you know, we practice infection prevention and control as a worker, but it doesn't stop us from being able to provide the full suite of services that that person needs from us. Angela, I know this is one of your hot topics. Go for it.
Well, it is, because it's been a question that I have been asked every single time for the better part of sort of nearly 30 years. And you're absolutely right. It's about the right, and that comes back to that empowerment and understanding the role that we expect of the care workers, and in providing the right tools and resources for people to understand. And so we need to have those facilities for people to be able to wash their hands without having to walk all, you know, to a hand basin that's for hand washing, that is all the way at the end of the corridor somewhere 100 metres away. It has to be available. We have to provide the right training. We have to provide the right supports to ensure that. But COVID all around the world showed everyone that the smaller household model, you absolutely have got much better capability of having good infection prevention and control. And you're right, it's about what you do in your own home. How do you manage your own personal hygiene, your own laundry? And you might say, oh, you know, but there are more moments, and there are, but that's all part of that whole practice, and providing the teams with the right level of resourcing to support good practices.
Thank you.
Can I just say, sorry, from a practical perspective, you know, when it comes to a lot of the practical aspects of the work that a house companion has to do, if you're doing the laundry, we do everything on an individual basis. So I'm taking that particular resident and their laundry out to the laundry. That's the only laundry that's going into that machine, you know, into the dryer, all of those things. And infection control becomes a nonity, essentially. And that's really, it is, again, about thinking about what's the work, how do I make the work work so that it actually still provides that individualised service.
Now we're coming right towards the hour, so I'm just going to put up some resources. Thank you both so much. I've really enjoyed this. I love chatting to both of you, and having the two of you together is really fantastic. There's some resources we're just putting up on the screen, which are basically saying you don't need to do this by yourself. DTA is it trains people across teams across the country. There's a whole range of different resources that we have. Chat Tool is a tool that we developed with the department in order to allow people to actually work their way through the principles and guidelines in a way that could check off what are the problems with a building, and could be used in a way that could be used for training staff. Like, we did the tool, here are the issues. If we make these changes, look how much better it will be. It can be used as a way of a before and after showing that you are going through continuous improvement. It can be used as a before and after to support a grant application. So the general resources that are on the next slide, there's a QR code that just links you to a hub that we set up specifically for these webinars. If you go to there, you get a link to the principles and guidelines, a link to the supporting environments course that we've been working with over the years to cover the same sorts of issues. You get a link to the chat tool and other training resources that people can come and can be part of, ideally as a team. As Angela said, I think it really is about how is this a team effort? Somebody can't shift a facility on their own, whether they're at the leadership role or whether they're one staff member. It really needs to be a team effort. Thank you both so much again. This has been really wonderful. I'm going to say also thank you to Naomi, Candida and Megan who've been supporting us on these different webinars, and all the team doing it, and Simone, and it's really been wonderful doing this for the department. So thank you for all the people behind the scenes, and hopefully you'll come and join us in 2 weeks' time for the next one where we talk more about gardens and how people get out to gardens. See you later.
Thank you, everyone.